Thank you everyone for being here and Dr. Roach for inviting me. I'm Victor Hernandez. I'm an associate professor of clinical orthopedics at University of Miami and Jackson Memorial System. We're going to talk today about rehabilitation and wearable devices, conflict of interest. I'm a consultant for Consensus, which has been involved in the development of this technology. This was my last talk in 2020 in person. Actually was invited by Roach to speak about this technology. At the end of this talk, there was a lot of conversation on why we were pushing this technology if it wasn't paid by the system. But we didn't know COVID was coming, and that made major changes in over a weekend. We have the Medicare and the health system approving telemedicine systems, and we have major changes on all these health systems. Not only within the health system, but also with the healthcare consumers. As you can see, in 2019, if you ask a patient if he was able to see a doctor using telemedicine, only 11% were okay to see that doctor. But nowadays, over 76% of them are able to see the doctor using telemedicine. And after a year of COVID, we have seen an increase of use of telemedicine everywhere. 20% of actual ER visits occurs through telemedicine, 33% of USA office visits occurs through telemedicine, as well as 35% of home care occurs through telemedicine. And it saved money for the patient. This is a study from Amwell, one of the insurance companies, that saved $38 per work for the patient in between traveling, waiting room, forms, and actual visit against just the patient see a doctor using telemedicine. And for the rehabilitation, it's a lot of use because in my center, we have a lot of people traveling from Central Florida 2-3 hours to see me have the knee replaced, and they go back, and the next available rehab center occurs within 2 hours. So it's very difficult for these patients to reach out to these centers. And this is not something new. Telemedicine has been used in the past. Australia has this randomized control study that shows result of telerehabilitation at 6 weeks were very similar. Even so, pain, flexion, and satisfaction were superior in the telemedicine program. This in Canada showed no difference using telemedicine versus non-telemedicine. And I started projects in 2016. We won an award and a grant for Health Trust for innovation. We were working at that time through the bundle payments with an outpatient surgery. We previously, in 2006, demonstrated that patients will be cheaper for the system to stay at home and do the rehabilitation at home than going to a center for rehabilitation. We started developing videos. We developed something we call the Little Home on a casita in Miami that allows the patient to feel at home. We go before surgery, 2 weeks before surgery, and the day of surgery, we go with the PT and OT to show the patient how to behave at home and how to do exercise at home. And then at that time, we have our nurse navigator. This is Mike. Mike used to cost $700 per patient. And what Mike used to do was tracking, coaching, and monitor the patient after surgery, making sure the patient was okay. Now that we have access to telehealth, we start thinking how we can use. And that's when we come out with wearable devices. Wearable devices is not something new. It's been used in endocrinology, cardiology, neurology, and other fields within medicine. And what exactly is a wearable device? It uses something is called IMU, Inertial Measure Unit. It's an electronic device that measures and reports the body-specific force in space. And it consists of an accelerometer, that is a tool that measures proper acceleration. That means the rate of change of velocity of a body in its own instantaneous rest frame. Use a gyroscope, which is a device that is used for measuring and maintain orientation and angular velocity. This is a spinning wheel or disc in which the axis of rotation is free to assume any orientation in space. And some of them use magnets as well. These start in space shuttles. They went into aircraft. We're using motorboats, used in sports. And nowadays we have in-car navigation, mobile games, digital cameras, balancing for robotics, and now we're using for motion sensors. And we have seen how everything has, in the past 2 years, has evolved. We have the My Mobility that is actually implanting some of these sensors within the knee replacement. we have the company Breck that has some of the technology to use for rehabilitation. And we inclusive has Tesla, which is developing this Tesla suit that has some of the wearable technology for rehabilitation and is using it with HSS to develop this technology. The one I'm presenting today use 2 wearable sensor units. Each one of them has 9 degrees of freedom and allows the device to be communicated in between the 2 of them by Bluetooth technology. They fuse the data and is able to determine numbers of steps and angle, the knee angle that the range of motion will cause. It goes to a flash memory. That flash memory goes into the cloud. And from the cloud goes to the system that I can see on my iPhone or my iPad or my desktop. Patients get the device 2 weeks before surgery. We start teaching how to use it pre-operative. And the patients, normally we go with the patient to do the exercise on the device. Patient get used to it. And then we balancing with our app. The patient also has another app that will measure week by week exactly the goals that we want for the patient, and then we can fine-tune based on patient's performance. They can send wound check, rate of motion, number of steps. We can even measure temperature from the patient, pain scores, different exercise, and we can also put scheduled pain controls for medications. I'm going to present a couple of cases that I have used it. This, for example, is a patient which after surgery we saw on the first week he was decreasing the range of motion, and we started seeing an increase on his pain control. So the pain after every exercise were almost reaching 7, 8, and patient started decreasing range of motion. At that point, we looked into the pain medication the patient was taking, and it was none. So there was no good pain control. We reach out to the patient, we teach them multimodal pain management, different techniques for pain control. And the patient, you can see how immediately after reassessment of the pain control, started walking better, doing better range of motion. This is another example. We have a lack of extension on this patient. Patient didn't take any of the pain medications. We went back, we teach them how to use them, and we kind of decrease a little bit for every week to not to push the patient too much for this patient not suffering and get a better control of the pain before pushing for more range of motion. And we have seen how the patient started decreasing on to the point that got from 27 to 10 of lack of patient. Or some of the disadvantage of this technology is they suffer something is accumulated error. It's called dead recurring. It's because the guidance system is continually integrating acceleration with respect to time to calculate velocity and position in the space, and any measure or error, even if it's a small one, will accumulate over time. As you can see on this graph, patient was for 119 and then goes into 150. So at this point, we know the patient, this is not real, so we have to go back, we have to call the patient, and we have to rebalance it. That takes time. So after rebalancing the patient again, we'll go back and we'll measure 180, which is what we expect for the patient. Another disadvantage is batteries. This doesn't last for more than 24 hours, so every night the patient needs to go. There's new technology that allows from some of the wearable device to, based on motion, to recharge these batteries. So that's a disadvantage if the patient needs to go every night and put it to the chart. We have sometimes patients that lost a couple of days of tracking because the patient forgot to charge even though the patient is wearing the device. And then patient compliance, in my practice, around 30% doesn't ended up using the device at 6 weeks post-op. The patients, some of them, they forgot. It's a difficult population we're dealing with. We have to make sure pre-operative, we teach them how to use and the importance of using it. And this is some data. This is based on 6 surgeons that we're using this device, 435 patients. We measured range of motion, pain scales, temperature. From this group, there was 3 manipulation under anesthesia, 2 side superficial wound infection with 1 tip, and 19 patients did not complete the 6 weeks data. And you can see from the baseline to 6 weeks is pretty similar. Patients increase on range of motion as well as on numbers of steps using the device. But you have to remember this is just proof of concept cohort study. There's a lot of limitations with this data, and that's what I'm not going to go into detail about this data because lack of a control arm. Right now, we're performing a level 1 study. We actually started this study in 2019, but secondary to the COVID, we have to stop. Patients with the randomized control for the rehabilitation didn't get the rehab they needed because most of the places were closing. So we put on hold this study, but we just restarted a month ago. So I hopefully within a year from now, I can present some of the outcome data. This is a randomized control study that has a group with just telemedicine and another group going to regular physical therapy. Thank you. Everyone in my office, starting from PT, OT, minors, my residents, has access to the app. So they can actually see my patients and they can roll into my attention if patients are behind or not. So that's one of the questions. This will make us a slave from our patients? I don't think so. I think it will make more connection with our patients. I've actually been working with this device since 2016. I didn't know any other device at that point that was available. I think most of the wearable device has pretty much a similar concept and it will work well. This is a device that I've been working with and I feel like I know it. It's like when you ask an orthopedic surgeon which implant you use, it's the one I've been using.
And talk real quick too on just patients' acceptance when you show them the wearable. Do they get overwhelmed? Is it age related? How do you kind of?
So that was my fear at the beginning is if the patient will accept. My population is over 65-year-old, but most of them nowadays they communicate with their family through Zoom and they have both. So I have not any rejections from patients. Actually, they love it. And I have patients who has come to me, ask me why we didn't use it on them. When they go to the PT, OT, they come back and they're mad to me because he doesn't have them, guys. No, I really didn't find overwhelmed actually we have seen a decrease in office visits and a decrease in office calls. I think the device allowed instant communication and because I have access to like the residents, the nurses, everybody can answer a question for a patient at any time. So we have seen a decrease in phone calls and visits.